Syringomyelia is a chronic progressive degenerative disorder in which there is formation of cyst or a cavity in the spinal cord. This cyst or cavity is known as syrinx. Etiology or cause of syringomyelia is congenital and secondly acquired. Under congenital, we have Arnold-Chiari malformation, familial, which is usually rare, hydrocephalus, spina bifida. Acquired, we have trauma, meningitis, hemorrhage, tumor, scoliosis. Types of syringomyelia. The first one is syringomyelia with fourth ventricle communication. This is seen in about 10% of the syringomyelia cases. There is a communication between the formed syrinx and the fourth ventricle. In some cases, a blockage of CSF circulation occurs. Secondly, we have syringomyelia due to blockage of CSF circulation. Here, there is a formation of syrinx due to blockage of CSF flow. However, there is no communication with the fourth ventricle. It is common in 50% of syringomyelia cases. Arnold-Chiari malformations, basal arachnoiditis, meningeal carcinomatosis, and arachnoid cysts are the causes of these types of syringomyelia. Thirdly, syringomyelia due to intramedullary tumors. Fluid accumulation is usually caused by secretion from the neoplastic cells or due to hemorrhage. Ependymoma and hemangioblastoma are the common tumors associated with syringomyelia. The fourth type is syringomyelia due to spinal cord injury. This is seen in less than 10% of cases. Mechanism of injury includes spinal trauma, radiation necrosis, hemorrhage, infections, cavitation following ischemic injuries or degenerative diseases. Fifth type includes syringomyelia and spinal dysraphism. Dysraphism means incomplete fusion. Dysraphism may occur due to various mechanisms. Sixth type is idiopathic syringomyelia. The cause is unknown and the mechanism is not clear for the formation of syrinx. Pathophysiology of syringomyelia. The most common accepted theories are: the first one is the Gardner's hydrodynamic theory. It occurs due to blockage of the foramen of Magendie that is blocked to the flow of CSF from the fourth ventricle to the subarachnoid space. This results in a water hammer-like transmission of pulsatile CSF via a communication between the fourth ventricle and the central canal of the spinal cord, which results in the formation of syrinx. The second one is Williams' theory. It states that syrinx develops in patients with Arnold-Chiari malformations due to the difference between intracranial pressure and spinal pressure caused by a valve-like action at the foramen magnum, which results in the formation of syrinx. The other theories include, we have Oldfield's theory, which states that syrinx is formed due to compression of neurons and blood vessels. Mechanism of formation of syrinx. The CSF or the cerebrospinal fluid usually flows in a pulsatile manner in the subarachnoid space and envelopes the brain and the spinal cord, as it helps in protection and provides nutrition to brain and spinal cord. Excess CSF in the central canal of the spinal cord is called as hydromyelia. When this excess fluid dissects outside into the white matter, it forms a cyst or a syrinx, which is known as syringomyelia. Prevalence of syringomyelia. Males are more prone as compared to females. It is usually seen in 8.4 cases per 100,000 people, occurs with a mean age of onset of 30 years, rarely develops in childhood or late adulthood. Investigations. MRI demonstrates the syrinx with any associated Chiari malformations, myelography, electromyography, lumbar puncture, X-ray of the cervical spine, and 3D CT scan. Here I have drawn a stick diagram in order to understand the clinical features better. So the first one is facial nerve palsy, ipsilateral tongue muscle wasting, vocal cord paralysis, abnormal or complete loss of sensations, wasting or weakness of the small muscles of the hand, shoulder joint is most commonly affected, scoliosis in the spine, autonomic nervous system shows bowel or bladder dysfunction, abnormal body temperature, erectile dysfunction, ataxia is seen in some people, Charcot's joints due to loss of pain sensory fibers of the joints. If the brain stem is involved, it is called as syringobulbia. Winging of the scapula if the anterior horn cell involvement is present, and hydrocephalus is seen in some cases. Management includes analgesics for headache and neck pain, surgery that is decompression surgery, suboccipital and cervical decompression, laminectomy and syringostomy. Syringostomy is where the syrinx is drained via a cylindrical tube into the subarachnoid space. Thirdly, we have shunts, which is ventriculoperitoneal shunt, indicated if ventriculomegaly and increased intracranial pressure is present. Syringo subarachnoid dorsal root entry zone shunt and syringoperitoneal shunt. Fourthly, we have fourth ventriculostomy. And lastly, neuroendoscopic surgery, wherein a fibroscope is inserted through a small myelotomy which allows inspection of the intramedullary cavity. This technique is particularly useful in evaluating and treating multiple separate syrinxes. Septa are fenestrated either mechanically or by a laser. The fluid from the cavity is then shunted into the subarachnoid space.